Please, can we do a recap today, Anna Menkoda?
I'll try and quit.
Let's do
a recap.
Okay.
Your phone says you.
Okay.
Good morning, sis.
Good morning.
Okay.
Okay. But please, let's try to keep our mic muted. If you have a question, now, what page then one person at a time so that we don't disturb the class. So last week, we discussed the management of the second stage. Please, can you hear me?
Yes.
Okay.
Yes,
so
we can hear you. When you finish, mute yourself.
Okay.
Yes.
So last week we discussed the management of the second stage of labor. And we said that, when the client is fully dilated, first you have to check the FHR. So you check the FHR. If the FHR is okay, then you scrub and you wear your PPE. Please, if I omit something, then you alert me, wipe. Then you scrub and you wear your PPEs. So the personal protective equipment, your apron, your boots, your goggles, and the rest. So you put them on. Then you push your already prepared delivery trolley to the bedside. Mr. Idrisu. Anna.
Yeah. Yes, please. Good morning.
Good morning.
Please, I wanted to make a different suggestion.
Okay.
If you people are okay with it, then please, some of the calculations. Yesterday, our network was bad, so we didn't get any. I was suggesting now that the labor is not in, and that way, like you can read and understand. I wanted to plead if it's agreed with you people, so that you take us through.
No, you can't use
somebody.
You can't do that.
No, we can't use somebody's period for this.
When she comes, she will not be happy. Even when
it will not be nice.
Even if HAJIA enters and we are doing calculation, it's not nice. Please.
It's not nice.
Okay, thank you.
Okay, so we can
one person at a time, please.
Okay, please continue.
All right. So after checking your FHR and putting on your PPEs, you scrub. That is where you wash your hand. So you wash your, we know the steps already. So you wash your hand, and after you push your already prepared delivery trolley to the labor room and the bedside of the laboring clients. Then you drape your clients. So in draping our clients, we were told to use 4 towels. And with the 4 towels, you put one on each thigh, one on the abdomen of the laboring woman, and one under the buttocks. So draping your clients, you need 4 towels. One on the abdomen, one on each thigh, and one under the buttocks, making 4. So after draping your client, you confirm second stage. And how do you confirm second stage? You do vaginal.
Please, 1 minute. The last one, you said we should put it at where?
One on the abdomen, under the buttocks.
Okay.
Yes, the one at the thighs. For what, please? If you can clarify.
For what? Look, I didn't write what for.
Oh, okay.
The abdomen one is to receive the baby.
Yes, for that one I know, but the thighs one.
Sister, please, who knows what the thigh one is used for?
But they don't normally do it at the ward, or my facility, we don't do it.
Oh, I haven't experienced that before. It's only the abdomen.
Yes.
But for the thighs, I haven't seen some before. The abdomen and the buttocks.
No. Hello. Please, can I say something about
one at a time.
You are not following your instructions. If you want to ask questions, raise your hand.
Raise your hand, I'll call you, please. Sister HAJIA, is it Matiti?
Good morning.
Good morning.
It's HAJIA Matiti.
Okay.
Oh, sisters, please, I wanted to plead with you. You made a suggestion, and everybody is just coming in talking. It's making the class very distracted. Please, if you have a question, you raise your hand and she'll call you and you answer. It's as simple as ABCD. Oh.
Thank you. Sister Juliana.
So I was saying that, have you seen normally at the ward, we use the big white cloth sheet to drape the woman's abdomen, and that will extend to the thighs. So with the four towels that we are using, one for the abdomen, two for the thighs, and it's more or less like providing privacy to the woman in case during the where you're especially not all wards have that private space for delivery. Some you see two people at a time and all of that. So it's more or less like providing privacy to the perineal area kind of thing. So we all know that on a normal day, we use the big white cloth sheets to cover the abdomen and extend it to the thighs. Do you understand?
Okay.
So that was what I was trying to say.
Sister Idrisu.
Yes, just to add up, that's what she rightly said. The ones on the thighs is just for privacy, so that you don't expose the woman.
Okay, thank you. So now we know what we are using the towels for. So after draping your client, you confirm second stage. So in confirming second stage, we do VE to confirm if the cervix is fully dilated. The cervix is full, all sides of the cervix are dilated. Then you educate your client. So you educate your client to push with contractions and rest in between contractions. So you tell your client to push with contractions. If she has the urge to bear down, she can push. If not, she's supposed to rest. Then you also educate your client, and you also allow your client to straighten her legs when there is no contractions to prevent foot drop. So if your client is fully dilated, you have positioned her in the lithotomy position. There is no contraction. We know the client is in the second stage of labor, but she doesn't have the urge to bear down. There is no contraction. You encourage your client, you educate your client to rest or straighten her legs. So she should take her leg from the lithotomy position and lie straight on the bed. This is to help prevent foot drop. And also, is that as the head advances, you protect the fetal head from tentorial tear. And how do you prevent the head from tentorial tear? Sister made us aware that you put your two examination finger on the fetal head and you spread it when head advances to aid flexing. So in preventing tentorial tear, you aid flexing by putting your examination finger on the fetal head and you spread it. Sister Idrisu, please, you have a question or a suggestion? Okay. So
please, you said on the fetal head and spread it.
Yeah, so you put your two examination fingers on the fetal head and you spread it when the fetal head advances to aid flexion. This is going to help prevent tentorial tear, to prevent bleeding in the scalp. Okay. So when the head advances and crowning takes place, so the head is now advances, crown has taken place. If your client is not roomy enough, if your client is tight, you give episiotomy. Start Cynthia. Hello.
Okay. Hello, we are listening, sister.
Hello, please. We put the two fingers there to allow the smallest diameter of the fetal head to descend. And you put the two fingers there to flex the fetal head to allow the smallest diameter of the fetal head to descend, so that there will not be any tear. That's what I heard.
Okay, thank you. Hello, HAJIA. Please, can you continue or you want to take over? Hello, sister.
Ahead. Please go ahead. Go ahead.
Okay. So when the head is
You are
crowning,
doing well. I'm listening to you. The only correction that I will make is the tie that you said you cover to prevent privacy. Is to minimize the rate at which infection will spread from the woman's thigh to the genitalia.
Oh, okay.
If it is left with privacy, what about if she's the only person in that delivery room? In some facilities, they have cubicles for delivery room. What about that? Privacy is maintained enough. Like you will use a towel, but you will still use it. It minimizes infection. So you please go ahead. I've joined you since long. So you continue. Please, I'm interested in the way you conduct the delivery. And I applaud to the whole class for contributing. It makes me happy because it's like you did understand what I've taught you. I'm so grateful. So please continue and let's see how the baby will come out. Go ahead.
Okay, sister. Thank you. Okay, thank you. So after crowning has taken place and your client is not roomy enough, if your client is tight, you give episiotomy. Then you ask the client to stop pushing after crowning has taken place. So please, why are we telling our client to stop pushing after crowning has taken place? Who can help us with that? Please, any contribution?
Yes.
Yeah.
To help
sister, to
with
prevent
extension
extra
of the word.
and then to prevent extra tears.
Okay, thank you. Sir Idrisu.
Oh. Hello.
Yeah, please, we can hear you.
Please, if you don't want to stop pushing, she will just push the baby out all of a sudden, then she will get tear. So that's why you tell her not to push again.
Okay, thank you. So after crowning has taken place and you've encouraged or educated your client to stop pushing, now we are going to deliver the face. So the face delivery or extension. So how do we deliver the face? With the face delivery, you spread your thumb and index finger of the left hand to get hold of the bitemporal bones to aid extension. So with the face delivery and extension, you spread your thumb, ukokromoti, and your index finger of the left hand. So you put it on the baby's face to locate the bitemporal bones. Then you flex it up to aid with extension. Also, you can also spread the right hand on the face of the baby and flex it upwards towards the symphysis pubis. So in doing that, we are aiding with extension and also delivering the face of the baby. Please, did you get it?
Yes, please. We
Yes,
did.
thank you.
Please.
Okay. So after delivering the face, we clean the face. So in cleaning of the face, we clean from inside outwards. And why are we cleaning the face? We are cleaning the face to prevent transmission of STIs. So in mothers that have sexually transmitted infections like the candidiasis and the rest, when the baby is out, we clean the face so that in case the mother has any infection, the infection cannot be transmitted into the baby through the eye. And cleaning, we don't clean anyhow. You clean from inside outwards. So use a sterile gauze to clean the face, the eyes of the baby. And also, you suction the liquor from the nose of the fetus if the liquor is meconium stain. So if the liquor is meconium stain, you suction the liquor from the fetal nose. So you suction from the nose and the mouth. And also so after cleaning the face, we have to deliver the chin. So in delivering the chin, you use the index finger to slip the chin from the perineum to deliver the chin. Sister Christiana.
Doctor, so the session, we do the session when the head is there or after you have delivered the baby onto the mother's abdomen. The session.
Oh, this one we've not delivered the baby. This one we've delivered the head and the face. So you see, most of the time, sometimes in the world they use the gauze to rub their hands and clean the mouth of the fetus if the liquor is meconium stain. So this one you're just trying to prevent infection, the transmission of infection. So not the suction you do after whole body is delivered.
Oh, okay. All right. Thank you. So use the penguin, right?
Sister Olivia.
Okay.
Yes.
Once the baby's face is inside the vulva, you use the penguin. I don't get it, please.
Is that?
While you deliver the baby's face, while the face is inside around the vulva, then you suction or what? I don't get it.
Can I add something? She says when you deliver the head, after delivering the head, the baby's head, that's when you do what our sister is saying. Or
hello, please
But we
let me
don't
come in.
mouth the faces,
After delivering
the
the
vulva.
yes,
Let's
raise
please
our hand.
hold on. Don't distract the class, please. Stop Portia.
Yes. So with what I can say with the suctioning, somebody asked if you have to suction before you deliver the baby. So as Sister Teresa said initially, if the baby came out and you can see the baby has already inhaled or aspirated some part of meconium or liquor, then you can suction. So it's a process we have to do. After cleaning the eyes, you suction. And with the suctioning, what I can add is sister also said that mostly suction is not always necessary, especially if the baby came out already crying. That one is outside. And with the suctioning, we have to suction the mouth first before we suction the nose. And that is to prevent aspiration, because when the baby is coming out, the baby is now coming to learn how to breathe on their own. So if you suction the nose first, the baby will end up aspirating. That is what I can also add.
Okay, thank you. So now we've delivered the face, we have delivered the chin, we have cleaned the baby's face and the eye. If there is meconium stain like for, we have suctioned the baby. So now we are going to feel for cord around neck. So we are going to feel for cord around neck. So with the cord, feeling for cord around neck, and after the head has been delivered, you use your fingers to move around the neck to see if there is cord around neck. Then if there is cord around neck, this is what you will do. So you slip the loosely cord over the shoulder of the head, over the shoulder of the head of the baby. So if you feel for cord around neck and there is cord around neck and the cord is loose, if it's loose, then you can put your index finger and your ring finger in between the cord and the fetal head. You try to slip it over the shoulders of the fetal head to remove the cord around neck. If the cord is tight, you have to clamp both sides of the cord to relieve tension on the neck, and then you cut. And in cutting the cord, you have to protect the cord. You have to cover the cord before cutting. If there is cord around neck and if it's loose, you slip the loosely cord over the shoulder of the fetus to relieve the cord around neck. If the cord is too tight and it cannot be slipped over, what you do is you clamp each side of the cord. So you locate the cord, you clamp each side, you cover and you cut. Then when you feel and there is no cord around the neck, you can proceed to deliver the shoulders. Start Getty. Is it Gertrude?
Juliana. Can I talk? Yeah, so with the cord around it, you can't slip the cord around the shoulder, off the shoulder. It says around the neck, so you just slip it off the head. You are using more of the shoulder rather than the head. So please, take the cord off the head, because if the cord is around the neck, there is no way it can get to the shoulder. Please, you understand?
Yeah, all right. Yeah, thank you. Thanks for the correction.
Welcome.
Is it Priscilla?
Yeah, she said that's the same thing I was about to say.
Yes.
I forgot to do on my hand.
Please, I've raised my hand for long. No one is calling me.
Okay, please, you can talk.
Please, so with the cord that we are saying is supposed to be around the head, please, there are circumstances that you can also flip it over the shoulder where it is loose. I've tried before, and it has been updated also that you can also flip over the shoulder if it's loose. So not only the head alone. And please, I want to add up, we have to wait for restitution before we deliver the baby to avoid shoulder dystocia. Thank you.
Thank you. Sister Diana. Anna. Is it Diana or Diane?
Please, Gifty. I
Hey,
have raised
start
my
Daisy.
hand for a very long time.
Okay.
Okay, sisters, please. I remember HAJIA saying last week that concerning cleaning of the eyes, we will use separate cotton swab. Let's take note of that. We will use separate cotton swab to clean the eyes. Thank you.
All right. Thank you. Okay. Please, can you continue?
Please let me say something first about what Sister Rhoda said. When
Okay.
in this case, we have only delivered the fetal head, not the shoulder.
Exactly.
Okay, so you cannot flip the cord over the shoulder. We have only delivered the fetal head, of which the fetal head is just visible. The shoulders are inside. It hasn't been delivered. So there is no way you can flip the cord around the shoulder. It can only be done around the head. Thank you.
Exactly what I was coming to say.
All right.
Please,
Thank
I
you
also
all.
have a concern. I have a concern.
Okay.
So with the secretion, it's not only when there's meconium. When there's secretion, you have to just suction. You have to just clean it because there can be infections in the liquor, which can the child can aspirate. So whatever secretion you see, you have to clean it up, not merely because of meconium. Thank you.
Okay.
Hello.
Thank you. So
Hello.
please. Yes.
Please, this is Rabia too.
Yeah, please, you can go ahead.
What
All right.
Rhoda said about flipping the cord around the shoulder. I've ever also done that. The cord was loose, so I have to flip it around the shoulder. So I think, sometimes when it happens, like it's an experience. So I think she's right.
Then if you say it that way, it means that you have delivered the body. You have
Yes, at this
delivered the
time, it's
body.
only
We are
the
talking
shoulder we
about
have
the
delivered.
delivered the
Please, who is
face.
speaking at the moment?
Juliana here.
Please, the
Okay.
baby is suffocating. Can we deliver the baby and later we ask our questions? Please. Please, let her get the baby out of the vagina, please. So that later, if you have any contribution, you can add. Go ahead, please.
Thank you. I'm going to kill my baby. So I'm praying for God. Then you deliver the shoulder. And how do we deliver the shoulder? So in delivering the shoulder, you support the head of the baby with both palms. So in supporting the head of the baby, you put both your left and your right palm on the head of the baby. Please, I hope you get what I'm trying to say here. So you support the head of the baby with both palms. So the left palm will be on top of the head and the right palm under the head of the fetus. Then you should not hook the neck to deliver the shoulder. Do not hook the neck to deliver the shoulder. And why are we saying that? We are saying that because if you hook the neck, it can cause Ehlers palsy or concused palsy. So we don't deliver the shoulder by hooking the neck. You deliver it with the head. So now, how do we deliver the anterior shoulder? So you first locate the sacromial diameter. Then you deliver the anterior shoulder with a downward traction. So you lift the head up a little. So after delivering the anterior shoulder with a downward traction, you lift the head of the fetus a little bit upwards to deliver the posterior shoulder. Then after the shoulder delivery, now we are coming to deliver the body of the baby. So with the body of the baby, you locate the bisacromial diameter. And we said that it is the largest diameter of the fetal body. So you locate the diameter. And the body of the baby is delivered laterally by putting your hand in the armpit or on top of the shoulder. And you lift the baby laterally to deliver by lateral flexion. So after delivering the anterior and the posterior shoulder, you can put your hands in the armpits of the baby to deliver the body of the baby laterally. Or you can use you can locate the bisocomial diameter to deliver the body of the fetus. And sister said we should note, if you deliver the body of the fetus and the baby comes out crying, there is no need to suction. If the baby comes out crying, there is no need to suction. You can only suction if your baby comes out and the baby is not crying. This is to prevent aspiration and also to prevent us from hurting the throat of the baby. So after delivering of the baby, your baby is crying, you do not suction. Baby is not crying, you suction baby. After you assess the ABGA, so the first minute ABGA score, you assess the first ABGA. Then you cover the head of the baby with a cap to prevent loss of heat. So we are trying to maintain heat. So after assessing the first minute ABGA, you cover the head of the baby. Then you put baby on mother's abdomen for skin to skin contact. So we deliver the body. We suction if the baby is not crying. After we cover the head, we assess the first minute ABGA. We cover the head of the baby. Then we put baby on mother's abdomen to encourage skin to skin contact. Then after putting baby on mother's abdomen, that is where we are coming to cut our cord. So with the cord cutting, we should note, do not milk the cord. What do you say milk? Some of us will be putting our hands on the cord to be pushing the blood backwards. So you do not milk the cord. Then you clamp the cord on each side and you cover before cutting. So you have to clamp the cord on each side, then you cover before cutting. So in clamping of the cord, our first clamp is placed about 5 centimeters from the baby's umbilicus. So first clamp, you locate the umbilicus of the baby. Then you measure about 5 centimeters, then you clamp. Then our second clamp is about 3 centimeters from the first clamp. So in all, we are clamping a diameter of a length of about 8 centimeters. So the first is 5 centimeters from the baby's umbilical. Then the second is 3 centimeters from the first clamp. Then you clamp. Then you cover the space in between the first and the second clamp with a gauze, a sterile gauze. Then you cut. We are covering or protecting the gauze to prevent splashing of blood. So you cover, then you cut. So after cutting the cord, you assess the second ABGA score, and then you cover mother and baby with a clean sheet to prevent hypothermia. Also, we tag the baby with a name tag. The sister said we should note, you shouldn't show the sex of the baby to the mother before delivery of the placenta. So you can only show the mother the sex of the baby after delivery of the placenta. And sister said this is because sometimes before you deliver the placenta, maybe the mother will be wanting a male child and she delivered a female. So if you show the sex of the baby to the mother will become anxious and it can lead to retained placenta, which can cause PPH. So you can only show the sex of the baby after you have safely delivered your placenta. Then you initiate breastfeeding within the first 30 minutes after delivery. Thank you. Please, any contribution, any question, any correction, any suggestion?
Thank you very much. Papa,
You didn't give up the
well. She didn't leave any points unattended to. I'm so grateful. So now that we have I don't think there's something to be added or subtracted, unless somebody wants to. So let's move on. Now the woman has delivered. The only thing is you didn't congratulate the woman. So you have to remember to thank your clients for doing well. Okay. So now baby is now on the mother's abdomen, because studies have shown that the first contact, skin to skin contact, makes the child so intelligent, brilliant. That is what they are saying. So that if you want your child to become so intelligent, so brilliant, then there's the need for you to at least ensure that the first skin to skin contact is ensured. Okay. So let's now see how best we can deliver the placenta. Is anybody ready to deliver the placenta?
Yes, Ajia.
Before the... Yeah, okay.
Yes, Ajia.
Your
but
name,
before the
please.
delivery, I have a
Abiva.
concern.
Okay. Go
Hello.
ahead. Hello, I'm listening
Please.
to you. Go ahead.
Okay, Ajia, before you start to deliver the placenta, there are certain cardinal points you have to wait, and they will take place. First of all, you have to wait and see if the cord, separation of the distant placenta from the attachment side. If the placenta...
Talk midwifery. The placenta site.
Hello.
What do you mean by
Hello.
the attachment site? Yes.
The maternal surface of
So
the
the uterine
placenta.
wall. Okay, go ahead.
So you see a gush of fresh blood. Then you clamp your cord in a way that blood will not gush or spread around you. Then you let it to be closer to the perineum side. Then you place your fundus, your left palm. You place your left palm on top of the mother's tummy in order to apply the...
What do you mean by tummy? Talk
The
abdomen.
mother abdomen.
So fundus.
In order to practice the CCT.
Fundus. Use the right terminology. Fundus. Of the
Fundus. So in order to apply the CCT called control traction, then you'll be pulling a bit.
Control cord traction, please.
Control cord traction. Then you'll be pulling a bit. If it is separated, you see that as you are pulling, it will be coming out. So, and you will be using your when it come out of the perineum, you use your 2 hands to support it and be coaxing it so that all the membranes will come out. Then you deliver it gently and put in a receiver for inspection. That's what I can see.
Thank you very much. Are you done? Have you finished?
No, you examine the placenta.
Let me ask one. Please, can I add up?
Yeah.
My name is Juliana. Please, before you deliver the placenta, you have to feel for seconds. You have to inspect the mother's abdomen by rubbing your hand on it to see if there is maybe an extra baby or something. Well, after doing that, then you give your oxytocin so that the uterus will contract to help in expelling the uterus. So if you give the oxytocin, you wait for a while to see. Then you use your control cord traction and try and pull the cord to see if detachment has taken place. If it hasn't detached, you wait for a while. But in doing that, you have to clamp the cord closer to the mother's perineum with an artery forceps so that will help you in pulling. So if detachment has taken place when you are pulling, it becomes easier and smooth. Then you receive it into your receiver.
Please, the one talking, the one on floor, your name.
Yeah, boy, Juliana.
Okay. Somebody is making noise with the children. I want to put them in the waiting room. That's why I'm asking your name.
Okay.
Go ahead, please.
Yes, please. So after inspecting for second twin and then being sure that there is none, you give your 10 units of oxytocin, then you wait for a while. Then you clamp the cord closer to the mother's perineum. That will help you to hold the cord when pulling. So in pulling, you don't just pull it right away. You pull it slowly in an upwards and in a downward traction, yes. A downward traction slowly. So if it has touched, it will become easier. Then you receive it. After receiving, you rub the mother's abdomen to see if there was anything left if there was clot, it will come out. If there is bleeding, some will come. You don't enter. So after receiving your placenta, you go in for inspection to see, you check the maternal side to see if everything, the lobes of the placenta are intact. If they are intact, then you clean the woman. But if they are not intact, that is when it's safe for you to go in to bring out the rest of the membrane or the lobes that was left inside. But if everything was intact in the placenta, there is no need for you to enter into the woman's vagina or the uterus to take out let products. Thank you.
Thank you very much. I'm grateful
HAJIA,
that.
please. HAJIA, please. I want to add up to signs of placenta separation. I think she only mentioned one. So there are 3 signs of placenta separation. We have the elongation of the cord. So you see that the cord is getting longer. And then there is fresh gushing out of blood, which she mentioned. And also the uterus will be firm, really contracted when you palpate on the fundus. Thank you.
I'm so grateful. I can see so many hands up. And please, before we deliver the placenta, let me quickly take you through the physiology of third stage of labor. Let's see what happens to the placenta site in the uterus before even we deliver it. We need to know the physiological changes that is taking place before the placenta is finally delivered. So quick one. I hope we are ready. Okay. So the physiological changes. As soon as the baby is out, the placenta not being a compressible organ, right? It will not be compressed, but then the uterus will contract, and by contracting, it compresses on the placenta. And so when it compresses on the placenta, what happens is that the placenta is compelled to separate from the uterine wall. The placenta is expelled, is compelled to detach from the uterine wall. And let's see the physiological changes, what actually takes place. There are 2 methods of placenta separation. One we call the Schultz method, and then the second is all in the slides, please. One is called Schultz method, and then the other one is called Matthew Duncan's method. With the Schultz method, the placenta will start separating from the center. It will start from the center. But then with the Matthew Duncan's method, it starts coming out with the maternal surface first. But I want to teach you what actually entails in the separation as to whether it is coming with the Schultz method or is coming with Matthew Duncan's method. So let's see. Placenta, please picture the placenta in utero, picture the uterine wall. So between the uterine wall and the placenta is what I'm going to tell you, the physiological changes. So what happens is that blood from the intervillous space of the placenta, blood from the intervillous space of the placenta, as soon as the placenta separates, it hasn't come out, but it's separating. Let's pick a situation where it will start from the center. That is the Schultz method. So what happens is that the placenta that has separated from the uterine wall, then blood from the intervillous space of the placenta, would then make an attempt to shunt back, to go back to the uterine wall, to go back and fill the maternal blood vessels. Or you can say to fill the maternal sinuses, the open sinuses. If I talk about maternal sinuses, I'm talking about open blood vessels of the mother's uterus. So the blood from the intervillous space will attempt to push back, to shunt back, to fill the open blood vessels of the uterus. Now, in that case, when it happens like that, quickly, the oblique muscle fibers of the uterus, the oblique muscle fibers, they are numerous at the body, while the circular muscle fibers are numerous at the cornua and at the cervix. And so the oblique muscle fibers, you can't find them in the cervix. They are not there in the cervix. But the circular muscle fibers are plenty and numerous at the cervix. And so let's see the activity of the oblique muscle fibers that is found at the body of the uterus. So once the placenta separates, we are saying that there's a shunt back of blood from the intervillous space of the placenta, attempting to fill the maternal blood vessels that are opened up. It is there that the oblique muscle fibers of the uterus will resist. It will resist by doing what? By forming what we call figure of 8 pattern. By forming what we call figure of 8, a pattern that looks like a figure of 8, to arrest, to entangle the open blood vessels. So that in that way, it is preventing the blood that is coming from the uterine wall. That is coming from the intervillous space of the placenta. It will prevent it because it is entangling the open blood vessels from behind. And so the blood from the intervillous space will not get access back into the maternal circulation. You see, nature is so wonderful. It will not get access to get into the maternal circulation. So that is the beauty of the muscle fibers. Some of the books are even describing it as a living ligature. They form living ligature. If you choose to say they form a figure of 8 pattern, it's the same thing. If you say they form living ligature, it's the same thing. But the purpose, the function of those oblique muscle fibers is the most important thing. So they entangle tightly around the blood vessels. Meanwhile, the blood from the intervillous space had managed to enter the open blood vessels, but could not enter the maternal circulation. They forced their way into the open maternal blood vessels, but they could not enter the maternal circulation because of the oblique muscle fibers entangling the vessels. So what happens is that wherever they fill up to, if I say they, I'm referring to the blood coming from the intervillous space. So wherever they have filled up to in the blood vessels, they could not get into the maternal circulation. So what happens? Why? Because oblique muscle fibers are restricting it. So at the end of the day, it tightens the blood vessel where they have filled up to. It fills up, it tightens it. There's no way. So what happens is that this filled up vessels will then rupture. Please, I'm teaching you the physiology of third stage of labor. If you meet anything in objectives or a full question, don't say HAJIA didn't teach us. That's why I've taken my time. I've taken my time for you to follow and understand. So now we are on a point where blood vessels are tightened up, but oblique muscle fibers are behind it, preventing the blood from the intervillous space to enter the circulation. So at the end of the day, these filled and tight blood vessels will rupture. It will rupture, and once it ruptures, it releases a clot. The clot that has filled up the vessels, it will then release a clot known as the uteroplacental clot. Known as the uteroplacental clot. Now, let's see the function of this clot. So what this clot is going to do is, it will then get back. The clot will then form on the placenta, on the maternal surface of the placenta. Now, when it falls on it like that, what happens is it causes more of the membranes or the placentae to get separated the more, because the clot is going to weigh the placenta down. And by weighing it down, weighing it down towards the vaginal canal. So as it weighs it down, separated. So that if it is coming, if the placenta is being separated by, it's a physiological change. If it's being separated and it pulls down, and it is the fetal surface that is the leading part of the placenta, then we call it Schultz method. SHULTUZ. No, TEZ. Schultz method. That is where the fetal surface will be delivered first. And in that case, the uteroplacental clots will be capped. It will be captioned on the maternal surface with the membranes like an inverted umbrella. It will behave like when it is raining and you are using your umbrella to walk through the rain. Sometimes the wind will just blow it up and the umbrella will be inverted. It will be inverted. That's a similar thing happening. So that the membranes will be able to capture the clots. It will enclose the clots. So that when you deliver the placenta, then there wouldn't be any blood messing up the delivery field. Because the clot has been captured by the membranes of the placenta. And that is the Schultz method of placenta separation. Now, in a situation where the maternal surface should come first, because the uteroplacental clots has been captured on top of the maternal surface, if the maternal surface should come first, what do you think will happen? If the placenta is coming out using the Matthew Duncan's method, what do you think will happen to the delivery field?
It will be
Anybody?
messy. It will spread out.
It will be messy. That's the right word. Thank you very much. The blood clots would then come out first. And so the delivery field, the test state management, the delivery field will be messy. It will be bloody. It will be dirty. And that is why some of the books call it dirty Duncan's method. Dirty Duncan's method. Other than that, it is Matthew Duncan's method. But because of the intraplacental clot messing up the delivery field, hence some of the books calling it dirty Duncan's method. Dirty because it is dirty in the delivery field by making the place so messy. Before, so once the maternal surface will come first. In fact, some books explain that it appears like when you are pushing a button, when you're pushing a button through a hole. That's how the placenta will behave. Like a button being pulled out of a hole. That is how it behaves. Hence, the maternal surface will be seen first, followed by the fetal surface. So that is the physiology of third stage of labor. Any question before I continue? Hello? Please, any question? Can I continue? Okay, now let's see. Like, I think the delivery of the placenta, the lady who described the management did very well. All that she said is true, and that is how to deliver the placenta. But remember, after all these physiological changes have taken place, after delivery, please let me know from you. Be sincere to yourself. Please just be sincere to yourself. The question that I'm going to ask. Those of you in the delivery suite, be sincere, be honest. After delivering the baby, when you're about to deliver the placenta, who is this person? It's like you are lucky. I nearly put you in the waiting room. Don't make noise because this is life and death issue here. If you don't deliver the placenta well, you are likely to expose the woman to postpartum hemorrhage. So please stop making noise. Stop conversing with the male in your womb, with the male voice. Didn't you people hear the male voice? Please be careful. Okay. So I'm saying that how many of us change the gloves that we use to conduct the delivery before delivering the placenta? No, let's be sincere to ourselves. Ruhaina Ali, I'm asking you. Hussein. Oh, just be sincere to what you have been doing. You just say it.
HAJIA, will be using the same gloves.
Thank you very much.
I have been.
Thank you very much.
I normally put on 2 gloves. So when it reaches that stage, then I remove the first one.
2 surgical gloves.
Yeah. 2 surgical gloves. Have you been doing it? Once in second stage, you are in a hurry to deliver the baby, you say you wear 2 gloves. But the ideal thing is that, please, for heaven's sake, anytime you conduct delivery after delivering the baby, try to quickly change the gloves. Change the gloves to a new one. Why? Why? Because it was this same gloves that you used to conduct the delivery. It was this same gloves that you used to pick fecal matter, the toilet that the baby used the face to sweep it out. It is the same gloves that you use to clean it. Why do you have to use the same gloves to conduct third stage of labor? You are exposing the woman to prepare sepsis. You are exposing the woman to severe infection. So please, let's go and effect a change to ourselves, to our clients. Make sure that you change the gloves. Then if the woman, the sheet that the woman is lying on, if it is so messy, it is so messy with meconium or the debris that you can think of, quickly take them out of the woman's, but from the woman's buttocks. Take it. Quick one, change your gloves. Then you put the end of the clamped cord into a receiver, a big receiver, of course, and not a small receiver. Now, let your assistant give the oxytocin drug, but before then, before giving the oxytocin drug, please, every hospital and its protocol. In some facilities, they use that just the gometrine. In some facilities, they give oxytocin. Some give pitocin. Some give symptometrin. Whatever embolic drug that you are giving, make sure that it is given before. You have to palpate the abdomen before you give the embolic drug. So you palpate the essences, some of the multiple pregnancies, some of the fetuses you may not be able to identify. The scan may not even capture the second twin. You see, and that is why there's a need for you to palpate the abdomen to ensure that there's no undiagnosed twin before you give the embolic drug. The essence of the embolic drug is to make sure that uterus is well contracted. But then if there's a retained twin that nobody captured it, scan did not capture, midwife did not see, nobody saw it, because there is a tiny baby. So in that case, you have to make sure that there's no retained baby or twins in utero before you make an attempt to give the injection. Now, there's one thing that I've also observed about midwives. When they're going to give the injection in the outer parts of the woman's thigh, some of the majority of them, they don't inform the patient. They don't. Patient is lying down after going through these labor processes. She's lying down, all that she could feel, chop. Then they are giving her the injection before you say, Kafra. What prevents you from informing the patient? She's a human being like you. You say what?
I say at times it's pressure.
Hello?
When you are
but pressure, but at least the dignity of the patient must also be observed. All of a sudden, somebody gives you yourself, somebody gives you injection. How would you feel? So don't let our patients take us on. So that is why you are there. Now, we are saying that after ensuring that there's no baby in utero, then you give the injection. But remember to inform the patient, at least win a cooperation. Madam, I'm giving you injection. This injection will help you so that you wouldn't bleed. You say it simply like that. It will help you not to bleed. We don't want a situation where you go home and come back with bleeding. Madam, that's why I'm giving you this injection. It will help you. It's her own body, but you have taken over control. Hey, her own body. And she shouldn't know what you are using her body for. Let her know. So that is it. Okay. Then after that, after giving the injection, after palpating, ensuring that, it is only a single-ton fetus, then you can go ahead and give the injection at the upper outer part of the thigh. Upper outer. You divide it into 3. So the middle portion outer, you give it. You give the injection to the patient. I've ever seen a midwife giving injection at the inner aspect of the thigh. She has heard that we give injection, we can give it on the thigh. And so any part of the thigh she was giving, before we could say anything, she had already given it at the inner side of the thigh. You are likely to cause deep bleed from both. So please be mindful. Okay, thank you. So we are saying that this woman is not having any twin. So we have given the injection. Now, when you give the injection, somebody was mentioning signs of placenta separation, which she mentioned them to be 3. Once you give the oxytocin drug, please don't wait for all the signs of placenta separation. Please, I hope you have gotten me well. Don't wait for all the signs of placenta separation. And then you feel for the uterine contraction. Use your 2 fingers to feel for the consistency of the uterus. Once the uterus has contracted, then you use your left hand to support the fundus. Use the left hand to support the fundus of the woman's uterus, and then you can now deliver the baby. You can now deliver the placenta. Don't wait for all the signs of placenta separation. That is the gush of blood, lengthening of cord, uterine contraction. At that time, will behave like a tennis ball, can move from side to side. Then it is well contracted. Don't wait for all these 3 signs. But then, with the 2, especially with the uterine contraction, behaving like a tennis ball, pick out one. Then you go ahead and give. You go ahead and then you deliver the placenta. In fact, the lengthening of the cord. In fact, the lengthening of the cord is not a very powerful point or a powerful sense or statement when it comes to the signs of placenta separation. Why? Because sometimes the cord is abnormally long, too long, and part has coiled up. Part has coiled up in the vagina. And so you holding it, it's like the coiled part of the cord has come out, and you think lengthening of the cord because it's a sign of placenta separation. So you go ahead and deliver the placenta. No. The best sign is the uterine contraction that you feel. Hello? Hello?
Hi.
Yes.
Are we going together?
Hi.
Okay.
We are here. We are here.
Yes, we are listening.
Okay.
We are listening to you.
Yes, we are listening to
Hello,
you.
That's good.
Hello,
Okay, so
good
That's
morning.
why.
you deliver
It's
the
okay,
placenta.
read
Now,
your
after
thoughts.
delivering the placenta, After delivering the placenta, you use gauze to wind around your two fingers of both hands. That is the middle finger and then the index finger. Use the layers of gauze to wrap these two fingers. So now these 4 fingers. Then you try to inspect the birth canal under good lighting system. It is painful at that time. So tell the clients that you are going to introduce your 2 fingers into the vagina to deliver the after coming head. To deliver after delivery of the placenta, to inspect to see whether the birth canal has sustained any injury. So you start the inspection from the perineum, then under good lighting system, you widen the vagina with your 2 fingers. Then you can ask the woman to push a little bit. Why? Because you want to inspect the cervix, whether he has sustained any cervical tear. So, mommy, push a little, just a little bit. She pushes and you can clearly see the cervix. Then you inspect for any bleeding or tear. Then you suture, you prepare, and then suture. Now, after doing all this, after this examination, then you clean the woman. And remember, the baby will have to be lifted up a little bit towards the breast. And sometimes you can get some stubborn babies clawing to go and then attach its mouth to the breast. Very beautiful. You see, then you tell the woman, Madam, get hold of your baby. Meanwhile, you have used one of your green towels to cover the baby and the mother. I'm talking about the abdomen. So you tell her, Madam, hold your baby. I've covered the baby. Baby is in close contact to your skin. Cover the baby. We have covered the baby. So hold the baby on top of the sheet. Support the baby very well. So baby will not slip off your abdomen before you deliver the placenta. Later, after that, the first thing that the midwife does after delivering of the placenta is to massage the uterus. Please take note of this thing. It appears that students will be choosing examining the placenta. The placenta that you had just a quick look at it at the bedside. We are not going to examine the entire placenta at the bedside. You had just a quick look at the placenta to ensure that it is complete. And you leave it in the receiver. But when you ask students, this question appears, what will be the first action of the midwife when the placenta is delivered, after the placenta is delivered? Then they'll be talking about examination of the placenta. No, the first action is to massage the uterus. You massage the uterus to contract and express the fundus. Because if it doesn't contract before you make an attempt to express the fundus, the uterus can be indented. There's something we call inversion of the uterus. The uterus will be inverted. The other lady described it very well. That's why I didn't go through it again. But whatever it is, when you are pulling the placenta, don't forget to support the fundus. It is very, very important. If you deliver it just like that without supporting the fundus, the patient will end up with inversion of the uterus. Why inversion? Inversion because probably the placenta has not been separated fully. It has not been separated fully. And you are pulling it. So that part of the placenta that is attached to the uterine wall will pull the inner part of the uterus, and then it will be inverted. And I'm telling you, it is one of the obstetric emergencies. The way the patient will scream, all the passerbys, all the nurses at the maternity ward, they will run to the delivery room to come and see what we are doing to the patient. The way she will shout. That's why we say it's one of the obstetric emergencies. So support the fundus, don't cause any uterine inversion. Then you deliver. And when you are delivering the placenta, follow the curve of Caros. Follow the curve of Caros. So that you pull the placenta down, you lift it up, and it comes out beautifully, following the birth canal. Beautifully. But if you pull it straight, that's where you get your retained membrane and retained clots. but just follow the curve of carrots. After you have twisted it, she did very well. That's why I didn't want to go over it. Just twist it, twist it, and it will form so the membranes will form something like a rope. It will all gather, and you deliver it slowly. No matter how hasty you are, when it comes to delivery of placenta and membranes, just take your time, because the tiniest amount of membrane that is retained in utero is enough to cause postpartum hemorrhage. It will prevent the uterus from contracting. When the uterus is tired, see. So that is it. That is all about the third stage. The most important thing is remember to examine the birth canal. Then you take the placenta to the sluice room for proper examination. Then after that, once your assistant takes it to the sluice or whoever takes it to the sluice, don't forget that you come and show the sex of the woman, of the baby to the woman. From the beginning, she said it. The one who described it, she said it. Show the sex to the woman for her to identify. At that time, that the placenta is out. Even if she's not interested in the sex of her baby, hardly will she go back into postpartum hemorrhage. Whether she likes it or not, if she doesn't like it, she doesn't see anything, you have to counsel her. Tell her if it's a baby boy that she's looking for, the girl that she has gotten, whatever a man can do, woman can do it and even do it better. So she should take it. If it is only boys, fine. Whatever a woman can do, a man can also do. So she shouldn't give up. She should just embrace that baby that she thinks is unfortunate for her to get another boy or another girl. Ladies and gentlemen, there you congratulate her. Thank her. She has done very well. So you take your items to the sluice room. Go and then you examine, do proper examination of the placenta. And then you decontaminate the items and decontaminate the placenta. Please, those of you who have been leaving your placenta in the placenta bowl just like that, it's not good. You are not thinking about the lady who or the gentleman who empties the placenta from the bowl. You are not being fair to her. So decontaminate the placenta also. You can even pour some of the bleach solution. After you have been collecting it from your patients, true or false? You've been collecting the bleach and Dettol and soap. Yeah,
Hajia.
Yes.
Hajia, good afternoon.
Good afternoon.
The main reason why sometimes we leave the placenta is that, some of the patient relatives, they take their placenta away. That is why we normally keep, yes. Because I had an issue, the man was a Nigerian. I didn't know they would take their placenta home. So immediately I was done, I poured it into the placenta bowl, and then the man told us to look for his placenta for him. So if you are done with delivery and immediately you discard your placenta, it becomes another 10 hours when the person needs the placenta. Yes.
But you are saying that whatever it is, this kind of thing has come up. It is an issue now. But the woman says, I need my placenta. Wrap it nicely in a polythene and then give it back to her. Recently, not quite long, I went to a facility. I was going to teach the students examination of the placenta. But normally I use live placenta. I don't use the model. I use rare placenta. So I'll go and look for it myself. And then when I went, fortunately, the woman had just delivered. So I said, oh, good. Then I'll get the placenta. And I happened to meet one of my past students there. So I was happy. Oh, I've met her. I'll get the placenta. Now, when she was about to give it to the man said that she said she told me that she was going to ask the woman, the husband, whether she will agree. The husband came. He said, Madam, I learned she wants the placenta. Me, I wanted to go and bury it myself. But I have to call the house to find out whether they will allow you to take it. I said, He said, yes. So this man he called Muzizongo, their people. that there's a tutor here who wants to take the placenta for academic purposes. Should we give it to her? Before the elder man said, okay, if only I will bury it without taking it for another thing. That people are using it for rituals and other things. I said, Madam, please, I don't need, I don't need your placenta for anything. I'm only going to use it for teaching purposes. Before the man said, then he asked the nurse, the midwife on duty, the one I went to meet, that she should see to it that I have buried it. And I said, she give me his number. During the process of burying, we took pictures. We took pictures, we snap it, and then I sent it to him. That he should watch me burying the placenta. So this day, that is what is happening. That is the order of the day. Ask the woman whether she likes her own placenta. If she says she likes it, then you give it to her. If you tell her and then she said, you ask her, do I have to put what do you call it, parazone on it, so it becomes safer for you to handle? If she said, no, you are going to use it for another purpose, then you wrap it nicely and give it to them. That's all. That's all. I learned some people, they prepare food for them to eat.
Yes, some people eat it.
And it is an old placenta. You should eat it.
Some people make it with smoothies. Then they will drink, or they will cook it and then eat it like meat. Oh, it is true. You can find out yourself.
Really?
Oh, but it's not. It's if it's not true, she wouldn't say it. What I'm
And
telling
some
you
also
is
make
true.
it like they take it to
So that is it,
those who
ladies
are
and
able to make
gentlemen. We
medicine.
are done with the placenta, but it's left with the examination. It's
HAJIA,
left with the examination. Yes, madam.
HAJIA, please, at my place, there are two things immediately the woman comes into labor. You have to hammer on it until she delivers. That is how she wants the placenta to be disposed, and then alerting her constantly that baby will be received onto her abdomen. These two things, immediately she comes into labor, you should be telling her, because there was a time, I think, one of our midwives who have gone on pension, they said they delivered the baby onto the abdomen, and then the mother tried throwing the baby away. So since then, it has become a routine. And sometimes when the babies come out, they are cold. And if you don't tell the mother, she will just feel the baby on the abdomen like that. Some of them may be tempted to even hurt the babies. So let's remind ourselves that we will tell them, cite them before we do that for them. Thank you.
Thank you very much. But are you aware of febrile psychosis? Are you aware?
Yes, sister. Very, very aware.
So that's the beginning of the febrile psychosis. So sometimes the mental state of the patient, you don't know. That's why when we were doing the delivery, managing the first stage, they said, examine the woman from head to toe to exclude abnormalities. For you know, she has come, but mentally she's not sound. She's not sound. And so delivering the baby and putting it on her abdomen without informing her, hey, it's a serious issue. Especially even the premipparals. The premipparal who has just received the baby for the first time. The first time in her life that a baby is coming closer to her, could put it in the pot. She's afraid. She's afraid of the baby. So communication carries a lot of information to both clients and then the midwives. On this note, we are left with about 30 minutes. Please, shall we examine our placenta? Two people will ask, Ninfasu, Vida. Vida, your hand is up. Tell us, what can I do for you? Yes?
Please, HAJIA, after delivery of the placenta, some people insert the hand to expel clots and then what have you. Is it necessary?
No, please. Please, those who have been doing that, they will stop. And I'm sure they have stopped from today. Please don't put your hand inside. This question came up the other time when we were doing the labor. Or maybe it's not your group. Don't put your hand inside the uterus in an attempt to bring whatever. Please don't do that. just consider the fact that uterine contraction is what you're interested in. Stimulate the uterus to contract and teach the mother. You have to teach the mother how to rub her own uterus. By the uterus becoming, firm, strong, and well contracted, there's no point putting your hand inside to go and bring the blood clots. Once you massage your breast, whatever is inside will come out. And that is why we also keep on hammering on the fact that you have to do early ablution after delivery. Early ablution of the woman is very key. Why? Because it aids the uterus to contract, and then it promotes local drainage. Okay. So once he gets up from out of bed, you see that if there's any protein retained tissue, it will come out by itself. It will come out. Even the cesarean section patients, the following day when you ask them to come out of bed, you see she comes out of bed and there will be a gush of blood, sometimes spilling on the floor. I don't know whether you have observed that. As soon as you help her to come out of blood, but that's why it's very important. Let her put on the perineal pad before you ask her to come out of bed, so that the pad can soak the blood that is supposed to come out. It will drain into the perineal pad instead of spilling on her leg and then on the floor before you are looking for a bleach solution to come and disinfect. So that is it. That is it. It's very important. Any more questions? Yes. Zanori, Regina.
Okay, Haja, please. Please, I wanted to ask when to assess the amount of blood loss.
When you take the placenta to the sluice room, we haven't examined the placenta, so the blood is still in the receiver there. We haven't examined the placenta. It is part of the examination of the placenta, yes, because we are going to school. That's why I'm asking. We are left with 15 minutes. Can I use that to examine the placenta so that we are done with third stage of labor?
Yes, Aja.
Okay, then quick one. Those whose hands are up, I don't know what they are. Chris Ladam, what do you have to ask? Deborah Misa.
Haja, please.
Yes.
I have 2 questions. Earlier, first one from when Misa was presenting. So the cord clamping. Some people say that we should wait for position of the cord to stop. In that case, there'll be a delay cord clamping. I don't know if that is right. And the second one is about not putting your hands to expel clot. The sponge holding faucet. I was told you wrap gauze around it, then you use to clean inside, rather than using your hand.
But who says you even use your hand? That is the first thing that we have disqualified that one. Please don't be doing that. Now let me ask you, sister, when you get your period, are you the one who put your hand inside the uterus to scoop out the blood before the menstrual flow comes? Every day?
No.
Put your hand inside the uterus. No. That's what I'm saying. Encourage early ambulation. Just massage the uterus, especially the fundus. Whatever is there will come. If you think we are going to examine the placenta, if you think the placenta is not complete, put the woman on a gometrine. Just put her on a gometrine 0.5 milligrams, maybe BD. Times 3 days, and to take care of anything that has retained there. Please, never ever put your hand inside the uterus after delivery. The infection is enough. The one has been exposed to infection is enough for her. Don't put your hand inside there. If you think you're putting your hand inside there to bring any clot, then I expect you to do that every day. Because once you are doing it, it wouldn't be enough. The best thing is let the uterus be contracted. Encourage early ambulation. Whatever has retained in utero, it will come out. Massage and express, and that's why we teach the woman how to massage her own uterus. That is the reason why. We have to teach the woman how to massage her own uterus. Why are we teaching her that? Why? What is the rationale behind? to get the uterus contracted and express fundus. Anything that is inside the uterus, that is left in cases of placenta subincubator, once you massage, it will come out. You don't need to put your hand inside there. And some of the uterus, it's okay. Why? I beg you people, don't be doing that. You introduce infection. The woman, the next moment, and those who use the forces and then the pack. If you are not lucky, you will leave. What do you call it? A piece of gauze in the uterus for the woman. She hasn't undergone cesarean section, but yes, and she's having retention of a piece of gauze in her uterus. She will end up with severe puerperal sepsis. She becomes septic. And if you don't take care, the next moment you are going to do hysterectomy because she's so offensive. Oh my goodness. Please don't do that. Don't do that. It's not a good practice. I don't know where they employ this thing from. Margaret Mars is not talking about that. Sylvia Veras is not talking about
they will
that.
come. I just called TK. He's coming.
You have a case,
There's no nose mask. I want to go and set up the place. I haven't seen any nose mask.
So kindly ask TK.
Hey, iPhone.
So that is it. Please, shall we examine the placenta? Last question, then we move on to examine the placenta. Yes, go ahead. Yes, sister.
Please, the barrister. Please, I want to clear my doubt on the types of placenta separation. At first, I learned that the difference between the two is that with the Duncans, the separation starts from the edges. So I want to know whether it is true or they all start from the middle. Oh, thank you.
Please, can somebody answer her for me?
The mouth
No,
starts
the
from
Swiss
the edge.
stands from the center, the Swiss.
The
And the
Swiss
Duncan. Yes.
edge.
And I even supported that with like a button. When
Yes.
you're pulling a button out of a hole. Didn't I say that just now?
Yes, please.
Please,
Oh,
I've
okay,
explained
sister,
it to you.
and I didn't get it. My network was breaking. That's why I wanted. Thank you.
I said it. I said that when I was explaining the physiology. Michelle's fuse vector will start from the center. Matthew Duncan will start from the edge, and it will behave like a button that you are trying to, remove from its hole, so that the maternal surface will be seen. Oh, please, I tube more light on it. It's true. Your light, your network went off because I stressed on it. Okay. So now let's quickly manage examine the placenta. In the examination of the placenta, we are saying it should be in the sleeves room and a good lighting system. Then it should be on a flat surface. My voice?
It's a bit slow.
It's true. Can somebody examine the placenta for me? Oh, please, those of you in the delivery room, can somebody examine the placenta for me? Please, Teresa, I will examine the placenta in the sleeves room. Oh. Who will do that for me, for a mark, for a score?
HAJIA, let me try.
Go ahead.
So, as you've already said, before you examine the placenta, you send it to a place with adequate lighting and at a surface where you can get space to spread it well. Then you check the cord to see. That's the fetus at the cord. How many veins and arteries were inside the cord there? They are supposed to be 1 vein, 2 arteries. Then you check the placenta and see whether there are patches on top.
If there's a missing vessel, what does it denote? If there's a missing vessel, You are looking for one big vein, two arteries.
You
can see it on the surface, yes. But then there's a missing vessel. One of the vessels is missing. What does it mean?
It's a placenta abnormality. It's a placenta abnormality.
And it indicates that the baby is having problem with the kidney. Some books are even saying problem with the ear. I saw it somewhere. It said it means the baby is having problem with the ear. One book also said, I think it was Margaret Mars, says that it's an indication that the baby is having problem with a kidney, with his or her kidney. So that is why it is good to examine for the presence of these three vessels. Good. Continue. We are examining it together. If you say something is not true, I mean it's not the way it's supposed to do, I will add up. So go ahead.
Then the loops. Actually, for that one, I've forgotten of the number of loops. It's like there's a particular number.
With the cord. Finish with the cord.
The cord, but I said you look for the two arteries and one vein. Then you look at the chorions around the cord, like the jelly-like. I don't know how to put it.
Oh, we call it Watson's jelly. Watson's jelly. W, somebody's name. Capital W-H-A-R-T-O-N''S. Then jelly. So what is jelly? You check for the amount. Let me quickly say it. The time is almost up. They will take us off any moment from now.
Okay.
So that I will have another class to attend. Let me take it.
Okay.
So we are talking about examination. We are. I'm doing it with you. Say your marks. We'll share the marks. Don't worry. I'll share it with you. Okay. So with examination, we said it has to be done in the sluice room. The first thing that you have to do is, first, when you pick the placenta, scoop the clots on the maternal surface and add it to the amount of blood loss in the receiver. Please do that. Scoop the clots on the maternal surface of the placenta, add it to the blood loss in the receiver before you measure. Okay. Now you check for the length of the cord. Sometimes patient was delaying second stage of labor, but you didn't know that the cord was so short. So one of the causes of delayed second stage of labor is short cord. If the cord is too short, please call me after the lecture. So I will give you the marks. Don't worry. You made a very good attempt. I'll give you the marks. Don't worry. So, but I'm taking it over anyway. So the length of the cord, I'm saying if a patient was delaying a second stage of labor, it is when you get to know that that's why this woman was delaying second stage of labor. The cord was too short. So in an attempt for the baby to descend down, the placenta was also pulling the baby back. That's why she can delay second stage of labor. It's just an example. And then the amount of Watson's gel on the cord, if it is too much, then after examination, go and revisit the cord stamp on the baby. Go and revisit. Why? Because if the gel is too much, it will cause the where you have clamped, it can cause it to slip. It can cause it to slip because the gel is so much to the extent that it may not be able to accommodate the whole of the cord clamp. And so you clamp, you think you have clamped it. But because of the bulky nature of the Watson's gel, it can cause a slip. It can easily open. And then you go and see baby has bled so much in the cord. It's one of the causes of cord deaths. It's one of the causes of cord deaths among infants or newborns. Okay. So you have checked for that, the cord. You have checked for the amount of it. Now lift the placenta up. You lift it up, you are assessing the completeness of the membranes. You are assessing the completeness of the membranes because if the membrane is torn, then it's likely that it might have retained in utero. If it is complete, fine. Then you have no problem.